Hello, everyone, and welcome
Slippery.
to Ask Us Anything. Help us if I hit record. Ask Us Anything. We're many episodes in now, and we're so happy to be here in August with you folks in 2020. We have the three co-founders here tonight of Immaculate Dissection, ready to just answer any of your amazing questions. I'm Dr. Kathy Dooley, one of your co-founders. Very happy to be here with the other two co-hosts, Dr. Anna Folkmer.
Hi, everyone. Dr. Anna Folkmer here. Super excited to answer some questions.
Super excited you're here. And Danny Quirk.
All right, cool. I can make noise now. Hey, I'm Danny. Excited to be here. Co-found one of the three co-founders of ID and the artist for Immaculate Dissection. So excited to partake.
So glad you're both here with us today, and I'm super glad to be here as well. So we have some great questions from some emails and some comments on our social media. And we also have a live participant here with a good question. If you have more questions in your live with us, just make sure to use the chat box to the left of the green button that says share screen. And we'll be more than happy to answer your questions should we get to it. If we don't get to it this week, just make sure to come in 2 weeks when we'll repeat this process of Ask Us Anything. Dr. Folkmer, we have some amazing questions coming your way. You've been getting a lot of repeat questions, a lot of the same stuff being asked over and over. And we thought we might just hit some of those out for the global masses so we can cover some of those questions. You've been getting some questions about the movement subsystems, is that right?
Mm-hmm.
Okay. And for the people that are not aware, Immaculate Dissection just released their first poster. We're pretty excited about that. Danny Quirk and Dr. Folkmer created a lot of what you have to see here, and the three of us as content generators collaborated together to expand the volemiine subsystems of human movement. These are not fascial lines, as Dr. Folkmer will describe in a second. Fascial lines are things that are coined by Dr. Tom Myers of Anatomy Trains. And in his book, he actually mentions volemiine subsystems and how they were one of the inspirations for his thought process. These are movement chains that actually occur not because of fascia, but because of what the structures are doing relative to respective phases of movement, particularly phases of gait. So we don't want to mix them up with fascial lines because they're not the same thing. This is about what the joints are doing, different phases of human ambulation. Intrinsic core stabilization, Danny has drawn this here. In green are the primary synergists, the things that actually make something happen with intrinsic stability. And that's the ability to earn gut pressure to stabilize the pelvis from above as you respirate. That's pretty important in all gait phases. There's not one particular gait phase that's more important in. It's pretty important for all of them. And then Danny has done a really nice job of showing you in red and orangish pink, respectively, the primary and secondary antagonists, things that antagonize the green and yellow structures. And so, like the deep longitudinal subsystem is very active during the mid-stance portion of gait, as well as terminal stance phases of gait. And then we also have lateral subsystem, which is crucial during frontal plane stabilization of your mid-stance. And I cannot seem to get my computer to work. Sorry, folks. There we go. And then anterior and posterior oblique subsystems are present. Anterior is very active during the loading response in human gait. This is not to be confused with the spiral line of the fascial lines. It's not the same. So that's why we tell everyone we're not the same as fascial lines. This is Dr. Volini's work and just expanding upon that with talking about gait. And then posterior oblique subsystem, very active during terminal stance. And in our ID6 coursework, you don't have to have taken our coursework in order to get our poster, but it will probably inspire you to take our ID6 online coursework. Dr. Folkmer has created this awesome chart down here because we do these things called perturbations, where we push into the system and see how it reacts. And we look for these expected responses and then see how the person deviates from the expected response. You'll see perturbations used throughout peer-reviewed literature and systematic reviews to look for motor control problems. And that's the way that we do it. And so Dr. Folkmer has created a little cheat sheet for what we find in perturbations. And then Danny's created a beautiful set of gait phases where you can actually see how they intermingle, and being able to explain a single limb support, double limb support, and weight acceptance, things like that. So he also has listed out every single gait phase and what are the most predominant subsystems in each phase. So if you're wanting to understand gait, that's when you look at movement subsystems. And it's how we prefer to teach gait in immaculate dissection. And it's, I think, the easiest way to teach gait, the best way to teach gait would be this one. Although there's many, many ways to tackle gait, we think that we offer something really special. And like people look at fascial lines and those are wonderful things to study, but they're just not the same. So we would highly encourage you to put maybe a gait poster next to your fascial line posters. That way you can see the differences and understand that these are functional movement subsystems, not connections of fascia. It's just very different. Not that one's better, it's not that it's one's better. It's about difference. There are different ways of looking at something. And there's certainly something to be said about looking at both and trying to tackle both. But I personally found severe limitations in my clinical practice just looking at fascial lines. It wasn't enough. And I also felt like I could connect fascial lines anywhere in the body because fascia is everywhere. So to me, it wasn't enough to be able to help me understand gait. But the movement subsystems do. I mean, straight out explains human ambulation through human development of the get up from 7.5 months all the way up to 13 months of the baby's development, but then also moving into watching the major gait cycles or major gait phases and then observing the gait cycle as an entity and showing how the subsystems play a huge part in that. And so in Immaculate Dissection 6, we break down those subsystems piece by piece. And that is a great way to fortify gait knowledge. Dr. Folkmer, is your quick answer to everyone that compares the subsystem fascial lines? I have to know what your quick answer is. Like when people, because people are so, they think that they're fascial lines and they're just not. These are movement subsystems of what actually is happening within the joints at each phase. So I'd love to know what your quick and dirty answer is because you're always beautifully succinct in your replies.
Well, I mean, they're more than fascia. It's like they're just, you're
Good
looking at the entire, I mean, not to, and again, just like you said, it's not to put down fascia lines. It's just, they're just more than that. And you're actually looking at the whole entire journey of pelvic stability or, force transfer as it pertains to pelvic stability and as it travels through these synergistic relationships throughout the body. The subsystems are relationships. They're not, they're not limited to just fascia. So this is the way that you build that intra-abdominal pressure, use it to create lumbo-pelvic stability, and then send that force transfer throughout the body. I mean, so many people are quick to say, it's all connected, it's all connected. And I think that that's a really fun, it's kind of a gateway drug, right? Like you can say that and then be like, ooh, I want to know more. And this is a really good way to see exactly, this is a great way to track that journey of force transfer throughout the body as it moves with us through life. And, if you can perturb somebody, you can apply stress to the situation and see where their vulnerabilities are. You can also see where it's sort of falling apart and you're seeing where the hiccup is of that journey of force transfer through the body along these movement subsystems. So, yes, it's not just fascia.
I love that. It's as much as fascia is important to the system, it's not more important than nerves and arteries and veins and connective tissue and bone and muscles. It's all very important. So when we talk about a movement subsystem, we talk about the fascia, the nerves, the muscles, everything that is a part of that movement that occurs. And so to limit yourself to thinking of things in just fascial terms is limiting you to one type of connective tissue and not looking at the entity that Anna's talking about, which is it's more than fascia. I love that response of it. It's more than fascia. It's a lot more. And when people start to understand that fascia lays down to muscular contraction, fascia is a slave to the blood supply to the area, fascia is also a slave to the nerve supply to the area, and vice versa. Fascia supplies information to nerves, arteries, veins, and the interstitium. It's such a crucial thing to not have a myopic viewpoint of just fascia. As much as I'm so glad that people aren't just throwing it in a trash can anymore, it's also equally important. Like people get very freaked out when we talk about nerves. And I'm like, I wonder if this is the way they used to feel about fascia. Were they dismissing it because it was all encompassing? It was so much netting, like there was so much to it. But anytime you've been to like anatomy worlds or body worlds, the body's exhibit. They have separate exhibits that will have just the nerves dissected out, just the arteries dissected out, just the veins dissected out, just the bones. And now we're looking at this fascial webbing. And then it's like, wow, if you start to realize that there's not just one thing, I think that if you look at things as a subsystem of movement, look at things, everything that contributes to the movement of that system, it becomes a lot easier to diagnose and treat a gait-related problem, a movement-related problem. Now, Danny, you and Anna created this amazing poster, and probably the most exciting piece of art in my house, other than the other pieces you've created, Danny. The work that went into it was pretty hardcore, and it took a long time for us to really start to nail down all the primary synergists, antagonists, because Bellini's work is very simply listed. What kind of went into your process mentally of understanding the subsystems in order to be able to create that kind of art?
Well, my whole stance is I'm coming into this aspect of knowledge and this aspect of teaching from kind of, I would say kind of an outsider's perspective. So like I don't have quite the same background that you and Anna have, but I have a general understanding from working closely with the two of you. So my whole stance is I want to try to make things as visually and easily understandable as possible. So through color coding, playing off a notion of traffic lights. Green means go, yellow means slow down, red means stop.
It was great.
So color coding throughout the course of this, this poster was, green is pure synergists, colors and structures that, would basically equate to proper optimal movement of structures and said subsystems. Yellow being slow down, yellow being kind of I shouldn't quite say antagonists, but ones that are kind of the mediators between pure synergists and pure antagonists. They're the ones that kind of get in the way, that cause you to slow down, the ones that kind of take over when you're not really performing optimally in a ideal setting. And then red being the ones that stop, inhibit, make you and prevent you from actually moving forward. So that was kind of the general direction color choice throughout the course of this poster. Hopefully, visualizing what allows for optimal movement, what gets in the way of properly moving, so on and so forth. But as kind of a follow up to what was said kind of prior to, I was kind of thinking about fascial lines versus what's happening right now, and fascial lines kind of being similar to like a rough draft of what's happening. And what's kind of being visualized here is like more of a polished draft. So rough draft, talking about the general structures that are happening, but the more polished draft, incorporating, arterial feed, blood supply, nerve supply, so on and so forth. And how it's not just a one system thing that's actually contributing, it's everything kind of working together to create proper movement, I guess. So
I really like that, the rough draft versus the final project. Well, this final project we're very proud of, and this poster is 24 by 36. It is $85 for the next month. When mid-September hits, it's going up, guys. We're taking off the 15% discount for the early birds and putting it to where it belongs at $100. But for now, we wanted to give you guys, the first people that invested in the poster, a little bit of cash out as a thank you to trust us with your education. We're so excited about this project. It's been in the work for years for us, and we're just really happy with the polished final draft, as Danny put it. So not fascial lines, nothing against fascial lines, but this is more than fascial lines. This is understanding human ambulation. This is gait. And people come to us all the time and say, well, which course do you take about gait? And we're like, ooh, that's a tough answer. But if we had to choose one, it would be 6. So if you're wanting to understand how to use the subsystems, the way that we use the subsystems, and how to correct for the problems, we do suggest the ID6 online course, $300 USD. Entire course is 15 hours of instruction plus, flows, if you will. We try to teach you how to best help your clients with the movement subsystems. That said, at the end of this talk, we will be giving away a free poster to the people that are paying the most attention and that learn how to use the chat box. So we're going to take the hit and actually pay for your shipping as well. So for the one person on this call that's live, that can answer one of our questions at the end, but you're going to have to wait because it could be anything we talk about in the hour. So look alive if you want to get a $100 poster for free. That said, we had some questions come through. One in particular was how ID handles the obliques, like what we do to strengthen, reset the obliques. We focus a lot on this in our ID1 coursework, ID1 core concepts coursework. And we're so passionate about the obliques that we have an extensive discussion. The entire first day is about the obliques. We did basically discuss it for a 7 to 8 hour period. That's how important the obliques are. There's not just some exercise we can throw at you and say, hey, do a crunch, or hey, do bicycles with your elbows alternating to the knees and hope for the obliques. It's not going to get it done. And a lot of people have oblique discrepancies because they have not done the hard work of understanding how to assess the obliques and what they even do and how they participate in human movement. So for us in immaculate dissection, the obliques are a big part of our ability to build and maintain gut pressure, and particularly internal abdominal oblique, transverse abdominis, but external abdominal oblique also participates in a big way. You also saw on the previous picture that we showed that the obliques are part of their own oblique subsystem of human movement. In ID1, we don't even get to that. We focus mostly on the building of pressure to stabilize the pelvis, as Anna talked about. You have to be able to build gut pressure, be able to maintain pelvic position. That way you have a pelvic fixed point for a moving femur. And that is such a huge piece of being able to stabilize the hip for a mobile femur on the hip. And since the femur it forms a ball and socket joint, the most movable joint you've got, with the pelvis, we need a stable platform for it. So intrinsic core stability is very important to us in ID1, ID6, but frankly, all the IDs. We talk about the importance of TVA, IAO, diaphragm, EAO, pelvic floor, how crucial these structures are, multifidus, erectors. But the way that we work on the oblique specifically is first through breathing. So we work on supine 90-90 breathing, where the person's laying on their back with feet planted at first, and then we elevate the feet. And what we're looking for is the ability for the person to have rib freedom, and a lot of people don't have it. Anna, when we study Chinese medicine, they often talk about like hypochondriacal pain and like tightness on the rib cage. Think about how stressed out people are in general, and think about how stressed out people are right now. The last thing they need is bicycles. You know, it's not going to do it. What they need is to be able to optimize 25,000 breaths per day to a place to where they don't build unnecessary tension or hypochondriacal pain or tightness on the sides of the rib cage. That's your hypochondrium. So the big focus for us, and it does take us 7 to 8 hours to teach it, is the ability to assess and maintain gut pressure. If you want the best oblique drill on the planet, make sure they can breathe in a basic supine and prone position. The stretch, if you will, to do a lot of turning and rotating with the trunk before you first allow the permission to relax on the inhalation move. A lot of people are missing that. And so they go to aggressive things like Roman twists and ball tosses to the side. And I've seen so many oblique strains in my office from these types of activities. And not that they're not great activities. If you have the freedom and permission to do them, they're great. Anna, you teach a huge chunk of this, and Danny, you paint this, so I don't want to monopolize the conversation. If someone were wanting to get really good oblique control, what do you guys usually tell people when they come to your office, or Danny, when they talk to you about the obliques? What do you guys have to share?
I mean, essentially what you just said, there's an opportunity to get really good oblique control 25,000 times a day. And if you're missing out on that, then there's a fractal effect of that, which is one of the things that is illustrated within even the subsystems drawing. It's so interesting how obliques don't occupy a lot of space in some people's conversations until they do, and that's going to be because of an oblique strain or because of a rib break or something like that. And so you know, I mean, these are the things, your obliques have the potential to really set the tone for a lot of, you know, what the upper body is doing, what the lower body is doing, where the pelvis is getting its cues from. Your obliques are massive. They connect your ribs to your pelvis. Like, how is that not important? And, you know, there's a potential for them to, you know, go through somewhat of a range of motion every single time you breathe. And so I think good oblique health is that, can it go, you know, can it receive its cue from the diaphragm, from the intrinsic system, and can it enter its range of motion fully and safely? I mean, I think that that's ultimately what we're looking at when we assess different structures. And I love that Danny refers to these patterns as traffic lights, because with these subsystems, like, not to bring it back to that again, but the obliques are a pretty big part of this. So, you know, with the subsystem drawings here, you can see everything that can go wrong, and you can see everything that can go right with them. And it's kind of like, I've recently started driving again, and when I'm driving down the road and all of the lights are green ahead, it's a good day. I'm so happy. I'm not getting stuck at any red lights. But, you know, so I think that the synergist and the antagonist pictures show you where those red lights are. Chinese medicine talks about traffic jams through here. They talk about the rib cage being sort of this, like, mobility center almost of so much of the movement in your body is reflected in your rib cage's ability to move. And we're not just talking about, you know, torsion and rotation and all that stuff. It's really just, can you breathe? Can they, there's a simple test. Can you breathe with them? Do they move when you breathe? Does one side move when you breathe? Do both sides move? Do they move more on an inhale or an exhale? You know, all of these things really, really matter. And my husband and I went frisbee golfing yesterday.
Oh, did you really? Fun.
And man, yeah, holy Moses, obliques are important with that, with any rotatory sports. But, you know, it got me really thinking and watching a lot about how, if that's not, you know, happening first and foremost, how many different things, you know, the fractal effect of that. And so, are you seeing green lights with these obliques, or are you seeing red lights with these obliques? Mm-hmm. And you can really just sort of answer that question with, how are they breathing?
Yeah, this is what Anna's talking about here, with the obliques being a huge part of the intrinsic core subsystem, especially the internal abdominal oblique. Not that external doesn't contribute, it contributes less to the building of gut pressure, and the things that antagonize it, things like diaphragm, pelvic floor, things like that. So we work really hard to harmonize someone's breathing first. And so our ID1 course is working on the breathing. And then once someone is able to nail that, which is hard enough as it is, then we move into the anterior subsystem. And that's in ID6. We make everybody harmonize breathing first, and then we move them into movements that combine the three planar movements of the obliques, which are flexion, side bending, and rotation. And so the obliques play a huge role in the loading response of gait. So if you don't think you're training your obliques when you're training a lunge, you are. If you don't think you're training your obliques when you're training a squat, you are. A deadlift, you are. And the great fallacy is people think they have to be on the floor doing a crunch or doing a bicycle to train these muscles. And it's not the way that it works. You actually train these muscles when you stabilize the pelvis, breathe through the ribs, and then move the limbs. These muscles react like milliseconds before your limb movements happen, especially transversus abdominis, which is part of that anterolateral abdominal muscle system with the obliques. So it's crucial to not fall into traps of thinking that this is an oblique exercise, and it's about being able to train the pelvis and then being able to rotate the trunk, or being able to fixate the rib cage as you elevate the pelvis in a couple of phases of gait. It's our best advice for you to train the obliques, but start with breathing and move through the subsystems. It's one of my favorite oblique drills. It does not look like an oblique drill at all. It's part of the get up. And when a person's on an elbow and they start to lift up their hip from that elbow space, I've had patients completely cramp their obliques doing that exercise. They're like, what? how in the world did I never know that this drill existed? And I'm like, well, you know, that's what we're talking about. We want to make sure that you understand that the obliques are very active in a lot of human movement. So optimizing breathing and pelvic positions are going to be pretty huge pieces. Okay. So we're good on obliques. What do you think, Danny, anything to add?
Oh yeah, for sure. So I guess so kind of in regards to obliques, obliques are kind of that mediator between extrinsic force and internal building of pressure. So made a quick little doodle roughly.
Awesome. Let me highlight you. Hold on.
Yeah.
There you go.
So this is a quick little arbitrary doodle, very, very quick. But if you can think of everything within this hexagon right here being core-based pressure. So things within the core, be it diaphragm, be it transverse abdominis, so on and so forth. A lot of those fibers are either going to be completely horizontal, being transverse abdominis, completely vertical, being diaphragm. But the obliques are going to have that 45-degree angle. And in having that aspect of that 45-degree angle, they're going to be transferring that pressure from built up in the core and letting them out to the limbs. So we'll have both the external and then internal. So external, we'll start with internal first. So internal being more of a core-based oblique, as opposed to external, which is much more extrinsic. But internal, it's going to be about a 45-degree angle upwards initially in its higher fibers, helping to be that mediator between building that gut pressure inside the core and then translating it to the external, which external is going to ambulate that pressure that is built from the arm, carried out into the leg. And that's going to be on that 45-degree angle roughly. So the obliques are going to play a huge role in transferring the pressure that's built inside the core, and then translating it to the outside force, through the arms, through the legs, through movements like that. So
perfect statement. Love it. It's true. And the fact that, oh, Danny, I think I turned your video off on accident. Okay, pin video. Oh no, Danny, turn your video back on. That was my fault. So basically what we want to make sure that you understand is that we don't do like one exercise for the obliques. There's not this magic bullet. It's about force transfer. So you're going to be doing arm movements, leg movements, just what Danny had said. It's very, very perfectly stated. Love it. Danny, thank you so much. That was awesome visual. Even your most simple thing is, to me, is like way better than I could have done. It probably would have taken me all day to draw that.
It's seriously 101, but happy it worked. So.
No, that was really good. Okay, so if you want to learn obliques, come take some courses with us. We'd love it. But some of our favorites are putting people through supine breathing, prone breathing, and the get up phases. Those are like quick and dirty things that we like to do for the obliques, of which the lunge is also included. So don't forget about how important the lunge is for building oblique power. Okay, so moving on, we had a question that was, there was a question about the hip, a couple questions about the hip. One was about degeneration of the hip. We had a patient that is experiencing pretty, or her patient is experiencing some pretty severe joint degeneration, and she wants to avoid replacement, which is really, really great. But the person is experiencing a lot of anterior thigh discomfort with her hip stability problems. I have no idea what the assessment is for this patient. I just had a question from one of our colleagues that said, hey, what do we do? The person, unfortunately, that asked the question is not taking the Immaculate Dissection coursework, because she would know the answer. So in our ID2 flowcharts, in our ID2 assessments, we assess the hip first from above the pelvis. So we make sure that the obliques, to be a broken record, are building that intrinsic force that Anna and Danny are describing, the ability to hold the pelvis up from above. And then once someone's able to do that, then we attack the femur from below, because in a stance of gait called mid stance, one of the major gait phases, It's where we spend a lot of time. Most of your gait phase, or most of your time in the gait phases are spent in stance phases, and mid stance is where you spend the most amount of time in stance. So when compared to some of the other phases, it's single limb support, which means you're on one leg. And so a lot of our patients with hip problems, they develop something called a hip decentration problem, where the hip cannot center properly in the socket with the hip, with the acetabulum, which is the acetic acid cup, if you will, a deep socket in the pelvis. And so imagine if the pelvis couldn't stabilize from above, the femur is not going to know where to go, and it's likely going to do what's called an arthrokinematic reflex, where it jams itself in its socket to create some localized stability for itself. It's a great way to degenerate the hip. The second way to degenerate the hip is to decenter it from its central part of the joint with the acetabulum, with the pelvis. And then it loads up with mechanoreceptors at the center of the joint, which tightens up the tissue around it when it's decentering. And then if you're really unlucky, it decenters just enough to hit the pain receptors, which are on the peripheral edges of the joint. And then you start to get a painful dysfunctional hip. So people tend to start off dysfunctional, non-painful, which is not what ends up in your office usually. Usually it has to graduate, if you will, to a dysfunctional, painful place. And that's when you start to see signs of degeneration, osteophytes, sclerosis of subchondral cartilage. You start to get like a lot of sometimes pitting of the bone. Sometimes you get cam lesions or pincer lesions of the hip. Femoroacetabular impingement are all pretty famous. But the discomfort the person may be feeling without an assessment, may be feeling on the anterior thigh, has to do with the femoral nerve, because it does the sensory innervation to that area, and all the structures associated with that area, things like pectineus, things like iliacus. And these structures are the primary hip compressors, so things that will actually keep the femur in the socket. So they do flexion, and then they'll start to encourage an internally rotating moment arm with iliacus, pectineus, respectively. So what you end up having is someone who can't properly stabilize the femur and then starts to load it. And that is a great way to degenerate a joint, to not be able to load share with the entire lower extremity, to not be able to load share with different sides of the joint from front to back, side to side, and then, putting excessive stressors on one part of the joint is how it starts to break down. You break down the cartilage, you build up the bone, and now you have a decreased joint space and not a lot of freedom and range of motion to get yourself out of it. Anna, would you like to tackle, you have a great discussion on labral tears. You teach the rectus femoris section and iliacus section of ID2. ID2 is where you start to understand hip in a really big way. And Danny paints this, of course, and Anna teaches it. And you have a great discussion on labral tear. So do you want to talk a little bit about why labral tears happen?
Yeah, of course. So, because it definitely piggybacks really nicely off of this discussion. And it's also, it's a common theme of a lot of emails and questions that we get often, which are, condition specific. And we always refer back to the same answer of you have to assess. And so labral tears also fall into that same category of, without that good hip centration, you aren't able to receive the force that you just hopefully, built into the lower extremity. And so there are strategies for that. And we talk in immaculate dissection too about how the rectus femoris is going to have a reflected head that actually attaches to that labrum within the acetabulum. It's a slightly lesser discussed attachment point, but it's certainly one that's there nonetheless, because when a person doesn't necessarily have the extensibility in the front of their hip that we would expect for them to have with good healthy hip centration, and this could just be because of the way they've tried to stabilize their hip or the way that they've tried to create a sense of stability. When we look at hip centration, we don't just look at it in one plane, we look at it all the way around. Kathy, I have to say, as you were talking, I was thinking about how I'm really missing our demonstration of joint centration.
Oh yes. So Anna usually acts as the femoroacetabular, or the labrum, or sorry, the acetabular rim, and then I act as the femoral head, and we show like centration with the the hip is going through all the time, all day long. It's doing this. It's trying, especially when it's load bearing, it's trying to react to the environment, and the class just cracks up and everyone laughs. But because we have no shame, obviously. And we also want you to understand that joint centration is not like abduction, adduction, flexion, extension. What Anna's talking about is this little reaction that's happening, and that is way more of what you're enduring throughout the day. And it takes a lot of sensory reception and a lot of reaction to have it. So Anna, labral tears are a form of decentration in the sagittal plane, mostly.
Yes. And so that I had no idea how much I missed that until like literally just now. But you know, the point of that whole interpretive dance, if you will, is that hip decentration doesn't just happen in one direction. It can happen really in any direction. And so we teach you how to look at that. And with labral tears, particularly when rectus femoris is involved, we are looking at potentially, you know, how well this person can move and centrate within the sagittal plane. But that's not to say that they aren't decentrating in other planes as well. We really start to, rectus femoris is a primarily sagittal plane dominant muscle, and so when it becomes dysfunctional, you may see sagittal plane issues, and you see this in their injury history as well, where you'll have someone who goes into hip extension maybe before they had permission to, and it just yanks a little bit of that labrum with it. Same thing can happen up here in the shoulder with the relationship of slap tears and biceps, long head biceps. So you're seeing the same kind of mechanics there, where essentially, you know, if you start to create demand on a structure before you've set it up for success, it will create symptoms. It will move. Your body is amazing. Apparently can live for a very long time. But it may not be without consequences. And labral tears are sometimes one of those things that can be consequential of moving into a position that we don't necessarily have a total foundation of success with. So we do look at a lot of sagittal plane decentration. You know, can this person actually enter good quality hip flexion and hip extension? Or are they trying to get their pelvis to do it for them? Where's your fixed point? Where's your moving point? Is your pelvis stable enough for your femur to move on safely? Or is your femur trying to jam itself in there for that sort of sense of stability, that false sense of security that it has, and then you're still creating that athletic demand of going into a range of motion that should, in theory, work perfectly if you have a good centrated femur. But if you don't, and you've sort of created some compensation strategies, who goes along for the ride with that when you do enter that range of motion? And a lot of times that can be where rec fem just yanks on the labrum, and then you got a labral tear.
Such a good description. And Danny, you paint this not only on the body, but on like a pair of pants that Anna and I will frequently wear. And it's so good because Danny's able to help you visualize the fact that, as Anna described, the rectus femoris is like the biceps. It's very similar to it, only the lower extremity is weight bearing. So we don't need the rectus femoris to directly attach to the labrum, but it attaches to the rim where the labrum is. It's right next to it. And you paint this very nicely, and everyone can see it. But I guess my big question to Danny is this: like, when you are like thinking of like the labrum, and you're thinking of all these hip degenerations, you as an artist and now as an immaculate, you know, dissection teacher, what would be your first piece of advice as what things people should look at when they get all these MRI findings thrown at them? Labral tear, hip degeneration, femoroacetabular impingement.
Well, I'd say the biggest thing is just really focusing on that load share right there. So recently, a couple of weeks ago, I restarted a job in landscaping. And, you know, a lot of that work is, you know, moving a lot of heavy loads in a wheelbarrow, you know, from point A to point B. And, you know, proper weight loading, proper weight share, that barrel is going to be loaded evenly, so on and so forth, to move forward with things. I often get in trouble with foremans and people on jobs are like, dude, you're taking way too long. But I will carry like literally double the load of what everybody else is because I'm loading that barrel properly from one side to the next. So there's not this like pull or tension from one side versus the other, whereas the other guys are just like randomly throwing things into the barrel. literally like 100-pound discrepancy from one side versus the other. So putting his time, energy, and effort to really like make sure that this barrel is properly load shared, properly weighted so that it can actually move forward properly. You're not going to have this pull from like a Y plane, an X plane, so on and so forth. And that's going to allow for a much heavier load to move forward and move forward in a healthy, stable way. So
I love that. The fact that the more centrated you are, the more load you can bear without any kind of discrepancies.
We were on a job site recently and like literally put about 45 more bricks in, comparatively speaking, to the other guys, because it was properly loaded from one side to the other, and like no tips, no falls, no anything. So
it's amazing. It's amazing how much like my husband and I are like collecting wood for our fireplace just in case the gas goes out, right? And we walked up to like a place. It's a lot of heavy labor, you know, hauling firewood. So we, you know, you're doing our corrective strategies beforehand, our ID stuff before we go. And then when we started doing it, we saw these two little piles, and they were these tiny little piles of wood. And we were like, oh no, we did not get much firewood. And then we start throwing it into the truck. And at first I was stacking it, and then I just gave up. And so we started tossing it in, and it was so much messy load compared to the little stacks of purple. It's like what you're describing with the bricks. Like the more like you can really center things up and stabilize it, the more you can fit and the more load you can bear without a discrepancy. And I just love that visual. It's so great. So for people that have like known structural changes, like I have a right labral tear in my hip, I don't feel anything. I used to, Anna does too. We both have had such similar problems with our right sides. And we no longer feel those things because we do ID stuff. We do a lot of hip centration work, a lot of core stability work from above, and a lot of hip centration work from below. And it's not traditional exercises like clams. Okay, clams are never going to teach you how to be able to load bear like Danny's talking about. You can clam 500 times, and then for a labral tear, for a degeneration, and then go on the work scene with Danny and tell me that clam did you any favors. No way. Danny knows how to load share on his femur. He knows how to keep his core stable. So if he's on one leg trying to pick something up and then push something over to the other side, he knows how to stabilize in each plane of movement. Since the hip has over 300 degrees of total range of motion in various planes, it's really important to know how to center it up. So I'm really, really glad that you said that. So we're really generic in ID, and we want it to be simple for you. We teach core stability from above the pelvis, and then femoral stabilization or pelvic stabilization via the femur below the pelvis. First, you have to earn the right to be able to hold your pelvis up from above, and then you earn the right to stabilize it from below. And for us, it takes 30 seconds of assessment. And we usually use our versions of a single leg stance, a half kneeling stance, and something we call a hip transition test. If you don't know these techniques, just take ID2 for crying out loud. It's one of the best investments that you'll make, because we'll be able to teach you a flow chart. We'll be able to teach you some basic functional tests, some good clinical pearls, and to know where to start. And we always make the joke in ID of where do I start? At the flow chart. And we try to get people, like Anna said, out of this condition-based thought process of labral tear, femoroacetabular impingement, blah, 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 blah. We just kind of turn a deaf ear to it and say, what's the assessment look like? Like, what is in front of me? Because there's this thing called VOMIT, victims of medical imaging technology, where if you say, oh, I got a labral tear in my hip, it's like you commit to that, and then, oh, it's a torn, so there's no reparation for that. There's no way I'll be able to get back from a tear. Bull hockey, right? You are not fragile. And so what you have to do, though, is learn how to be assessed properly and corrected properly. So we highly suggest ID2 coursework. We'll teach you in the first hour. Everything you need to know for the 15 hours is in the first hour, and everything else is icing on the proverbial flowchart cake of that first hour. So hopefully, if you're still confused about hip and centration of the hip and what that means, and you're still stuck on condition-based stuff, oh, I got bone on my hip. Bull. Okay, the research is showing that terminology needs to die away, because it's just not true. And so when it comes to osteoarthritic changes, degeneration, labral tears, get an assessment process and stop being so condition-based. Consider the fact that assessment-based may serve you a little bit better. Cool. Now going on to the shoulder, the other ball and socket joint. Someone had asked about overhead limitation, like when you get to a 90-degree angle, why so many people have such problems in internal, external rotation. So I think the crowd, anyone watching for a second, should follow the ID cues for a second. Neck long, chin back, chest wide, ribs down, pelvis even. Okay. Those 5 major cues are what we do to create spinal stability, which is pretty important for the shoulder, right? For any joint. Keep that stable. And then now just do a common test called reverse Apley's. Okay. Take the arm and put it back here without changing any of those cues. Okay. What you did was one of the more complicated things your shoulder will ever be asked to do. Okay. That action you just did was a combination of flexion of the shoulder joint, which is closing off its surfaces, right? Abduction, which is movement outwards, and external rotation, right? In a world where we don't follow the ID cues, let's now pretend like we've been behind our computer all day with no one looking, okay? Let's do what Anna's doing, like here. Danny's like this, okay? And then now try to do the same thing. And ask yourself if it were more difficult. Yeah. So all shoulder problems start as cervical spinal problems that started as core stability problems. So we need to make sure that the person has a very stable spine, what Anna referred to as abdominal lumbopelvis. So good abdominal pressure, good lumbopelvic stabilization, because that's your center of mass. So L4 to S1. And then you have to be able to maintain our IDQs because the neck is involved in a functional joint in the shoulder. So the neck also innervates all of these structures. So if you have any chance of getting an overhead position that's safe, you will first maintain core stability and then have a stable neck. Those things are really important. So if the person's doing a dive, to reach, it's a fail, okay? Now, in order to do that reverse Apley's move, you had to move 3 major joint articulations that are physiological. One is the very, very famous glenohumeral joint, which is an utter and complete slave to the 2 other bony articulations, which are the sternoclavicular joint and the acromioclavicular joint. All right, so those 3 are the bony articulations of the shoulder girdle, okay? And then there are 3 other functional joints that are also moving when you just did that. A very important one is called the scapulothoracic joint, which is a functional joint made of muscles, not bones. It's muscles that connect bones, right? So these are things that go from the cervical spine and upper thoracic spine and ribs over to the scapula. So it really should be called scapulothoracic cervical costal joint, but it's not. It's called scapulothoracic joint, but it involves structures that come all the way from like the head and neck down all the way to the rib 9 and then connect over to your shoulder blade. So it's a massive amount of muscles that have to coordinate. And if someone has problems coordinating these soft tissues, these muscles, then it creates a functional impairment on all of the joints of the shoulder. Another functional joint is what Anna was describing with labral tears of the shoulder, SLAP tears, superior labrum, anterior to posterior tears. So the glenoid labrum deepens the socket of the scapula to accept the head of the humerus. Because the head of the humerus, it's kind of like balancing a gigantic softball on a golf tee. Okay, so the labrum widens it out so that you can have a little bit more surface area. And then to check and balance yourself so that you're not an idiot, the labrum is attached to the long head biceps. And the long head biceps is not attached to the humerus at all. It's attached down to your radius. So it's trying to keep you in check just in case you overreach behind you or you don't have good coordination. The biceps can add tensile force to prevent you from tearing a bunch of other stuff, but it might tear your labrum. And so SLAP tears 2 and 4 actually involve de-anchoring of the biceps away from the glenoid labrum. And it's not a labral problem as a sole entity, just like the hip problem is not a hip labral problem as a sole entity. It's an entirety of joints. And this is way more complicated than the hip because we still have another functional joint made from the subacromial bursa. So there's a fluid-filled sac that many of you guys know as being painful that sits between the deltoid, the acromion, and the head of the humerus. And it's often called the subdeltoid bursa or subacromial bursa. It's actually 2 different bursae that kind of conglomerated like a bow tie, and they sit right underneath the high point of your shoulder. So a lot of people come to you and say like, I have pain right here. And you're like, okay, oh, that doesn't tell me anything. I'm gonna have to assess 3 major joints. And those 3 major joints for us in ID are taught in ID 3. And those joints are the scapulothoracic joint, the acromioclavicular joint, and the sternoclavicular joint. You're probably wondering, well, what about the glenohumeral joint? Well, think about it. If the scapula cannot stabilize relative to the neck, the thorax, the ribs, how in the heck can it be a nice fixed point for the moving humerus? If it's moving too, everything's decentrating. So you know what the humerus will do when the scapula is moving like that? It'll fix. So that the muscles that attach from the shoulder blade to the humerus, like the rotator cuff muscles, so that they don't tear. So just because you have a rotator cuff muscle tear, or just because you have a limitation in reverse applies, doesn't mean we go to the glenohumeral joint first. We don't. In immaculate dissection, we spend the first 7 hours of day one talking about the SC joint, the AC joint, and the scapulothoracic or ST joint. So we try to coordinate those 3 joints that are the most proximal, that create stability for the clavicle and scapula, so that we can have a humerus that has the permission to move. And our big secret in ID is that no matter what the problem is, whether it's a ganglion cyst on the wrist or whether it's elbow tendonitis, we always look up here first, ST, SC, AC joint. So if someone has trouble being able to move their arm overhead, you're having to limit them from overhead movement. Remember the discussion we just had about if this is unstable, how can you reach, right? So make sure that they have good core stabilization, neck stabilization first. And then in order to be able to do that movement, you're going to have good coordination between the clavicle and scapula and the general muscles that attach to all of those bones before you even have a chance to really think about the humerus doing the job. It's not really doing much till you get to here. It's doing very little until you get to here. It's asked to do a ton and need a stable platform for it when you move your arm overhead. So if someone's having trouble over 90 degrees, don't look at the humerus first. Look at ST-SC-AC joint. And you can come to ID3 online or in person, and we could teach you our flow chart for that as well. A little bit more complicated than the hip. In the hip, we teach it in 30 seconds. And, you know, it takes about 45 seconds to assess the ST-SC-AC joint. Ooh, you know, but it is, you know, 3 joints instead of 1 primary joint at the hip. Anna and Danny, I'm sorry, I monopolized that. I got heated up because I get so excited talking about overhead movement. Wonderful things to add from the amazing co-founders.
Well, I don't know about wonderful things, but I was just sitting here thinking, you know, when I was a teenager, if I wasn't out and about doing neat things, it's probably because I was grounded. And so if your body is if your body is not doing neat movement in a full range of capacity, it's probably because it's grounded. And so rather than just forcing it and moving through that and, you know, moving through those yellow lights, as Danny calls them, check to make sure you're set up for success, check to make sure that you have permission, check to make sure you aren't cutting any corners, or you get grounded. And so I find it comes back to haunt me all the time. And yes, absolutely, anything on that upper extremity, you start here. You start here, you start here, you start here, you here, and then here. But you don't start here. And you know, you really do have to just sort of make sure it's set up for success, make sure everything is receiving its cues. If it's not receiving its cues, it's gonna kick in, it's gonna do its own thing. It's gonna just say, oh, well, I'm gonna just I can't wait around all day for that cue to come in from my neighbor, so I gotta just full speed ahead, push through. And again, you know, your body also conveniently puts pain receptors around these things to help keep them in check. So symptoms and limitations, they're not, you know, I'm so sick of hearing that called aging. It's not about aging, it's about permission. And so, you know, does your body have permission to go where it needs to go? Are you asking it to do something simultaneous to not setting it up for success?
Because your body grounded you. You're grounded.
Are you grounded this weekend? Probably.
I think it's really fascinating. Like I had a patient that came to me a year ago, and she had pretty severe MRI findings in her shoulder, and they really freaked her out. And I said, okay, this is a piece of information. It's not on its own a diagnostic piece. It's a part of a differential diagnosis. And so we can't just be irradiating people and saying, oh, that's the problem is because you have this tear. I'm like, wait a minute, I could probably irradiate your other shoulder and it doesn't hurt at all. And you probably have some tears in there. So I need more information than just a postulate. So an idea, we go through a really strict assessment process to so that you don't get grounded. We establish the rules so you know how to follow them. And it's really a crucial piece to understanding. And my patient was very patient with me, and I explained that I couldn't let her go overhead until she had permission. She had to pass certain parts of my exam, and then I would permit her to go overhead. So she let me limit her overhead motion as she started working on things. And in our appointment today, this morning, she's in Israel, and in our appointment today, she was like, you're never going to believe what happened. And I said, what? And she goes, I have zero pain in any position, and it started yesterday. And she goes, I didn't notice it till it was gone. I didn't notice that there was no pain anymore. And for her, it was a long process. You know, she has an inflammatory condition in her blood that makes it harder for her to do things. And so it took her a year to fully rehabilitate all those nasty MRI findings. But she was showing me, she's like, look what I could do. Look, look, look. And she was like doing this. And she was so excited. And we're both like crying, like with laughter, because she's just having so much fun with the fact. She's like, it doesn't hurt. It doesn't hurt. I don't know why, but it doesn't hurt. And I'm like, yes, you do. You know why? Because you've committed to a daily practice of understanding.
Kathy, I think we lost your audio.
Better? My headphones are really finicky. Sorry. They're supposed to be super expensive, but they're just really expensive pieces of crap. Sorry. My husband's. The thing that she got so excited about was the fact that she thought that she was subscribed, because she's in her 60s, she thought she was subscribed to a life of like, I'm a postmenopausal female with shoulder changes and nothing's ever going to get better and blah, blah, blah. Because her doctors had told her, you know, this story of, you've got AC joint sclerosis and a rotator cuff tear, and you got biceps tendinosynovitis and a little bit of, you know, all this crap, all these things. And I'm just like, that's just an ICD-10 code. It's not necessarily what you're subscribed to for a lifetime, and you have to change your habits because they don't work for you. And she did, and I think it's just so excited that she has a pretty severe genetic disorder that leads her towards inflammation. She has a perfect excuse not to do anything, and she doesn't use it. She walks like 9 miles a day in Jerusalem, and she just working so hard on trying to get it. She trusted the process being a challenging one that might take us some time. So it did take her a year to earn her overhead position, but she earned it, and she will keep it because she now understands the importance of the ST-SC-AC joint. We barely even worked on her glenohumeral for a long time because we just had to coordinate everything to not like be in her ear all the time or roll forward all the time. She had to learn how to maintain the IDQs. And when she did, when she built that habit, she got what she deserved, which was a lot of relief, a lot of improved range, a prevention of she came to me with frozen shoulder, basically. That's what her diagnosis was, although there was a lot more going on than that. And so she's just really, really happy now, and she's earned it, but she followed the rules. And so we're going to make anyone NID follow the rules. And as our patients and our students, we're going to make you all follow the same rules of understanding the joints in that order, ST-SC-AC joint. And then you get to glenohumeral joint later, because it's a slave to what's happening at the ST, scapular thoracic, SC, sternoclavicular, and then AC, acromioclavicular joints. Okay, I think we're out of time, right? Shoot, that was really fun. I think we got through all the questions though, and no new questions popped up during the feed. So hopefully some people are still paying attention because we got some free stuff to give away. So I'm hoping that the first person that answers this question correctly will really enjoy our gate poster. And just in case you came in late, we're giving away one of our ID gate posters. It's our new product we're very excited about. It's 24 by 36. You're not going to pay for shipping. You're not going to pay for anything. So basically you're going to save about 120 bucks just by answering a question correctly and paying attention. Okay. So I have a good question. Is it okay if I ask them a question, guys, or do you have one that you want to ask? No? Yeah? So I want to see if anybody was paying attention to Dr. Folkmer. Okay. I want to know the main muscle that's related to a femoroacetabular labral tear, a hip labral tear. Often forgotten about muscle. A reflected head. Ah, we have a winner. Fantastic. So what you'll want to do is you'll want to email immaculateDissection@gmail.com. And I bet Anna will actually type that in. And so thank you for being our amazing big winner. It was Anne. I don't know who Anne's last name is on that. So just make sure to email Dr. Folkmar. She's putting the email in now into the chat box. And she will give you a special code that you'll use to be able to get a free poster with no shipping. So it's coming to you in about 3 weeks if you are in the States, and give us up to 6 weeks depending on what's happening with the pandemic for you to get yours international order. So hopefully sooner rather than later. For everyone else that came to listen, we really appreciate your questions, your time and attention. Any last words, Danny, to share with the group before we leave?
Well, let's see. So kind of on the topic of shoulder stabilization that we're talking about beforehand. Was kind of thinking about a little bit of a visual in regards to a slingshot. So in regards to keeping stabilization for movement. So if glenohumeral is completely reliant upon stability of the sternoclavicular, the acromioclavicular, and then the and then the scapular thoracic joint. It's thinking of a slingshot here. So if the core stability is in essence what you're holding, if that's not stable, that's going to throw off where you're actually shooting. In regards to actually pulling the line back, which would be equivalent to the scapular thoracic joint, if that's moving all the way around, that's going to have some issues as well. If you're going to have some movement between the sternoclavicular or the acromioclavicular, that's going to kind of throw things off. So you want to have a really stable joint to be able to pull that back and shoot forward and actually hit your target from there.
Beautiful. I love it. I love the slingshot theory of misaiming and your aim going in the wrong direction based upon those 3 joints. I love it. Fantastic.
Well,
Dr. Folkmar,
sorry. No, you can go ahead.
I'm so sorry. I talked over you. My apologies. Dr. Folkmar, any last words for the group?
Just thanks so much for joining us. Thanks for submitting your questions. Keep them coming. We will definitely answer them as we see them. And before you type in a condition-specific question, remember the answer is probably, did you assess? And what was your assessment? And it doesn't matter. Nobody gets a pass. We always say that in ID courses. So feel free to keep sending those questions in. We'll keep sending those answers right back out, and we'll meet again in 2 weeks to chat about this stuff some more.
Love it. And if you guys want to join us on Tuesday, if you guys haven't heard of the ID Collaborative is separate from the ID courses. It's open to anybody that wants to talk about anatomy, and we talk about things that we don't necessarily get to talk about for like an hour in our coursework because we have so much to cover. So sometimes we do condition-based stuff, but this week on Tuesday, we are doing a great talk on the anatomy of movement subsystems, which is basically that poster that you saw, and one that Anne won. So you might want to come and just hear, what the heck are these subsystems again? Like, what is it? It's a $20 talk. If you're part of our yearly membership, all the talks, you get the entire year of talks for $209. But if you just want to join us for the subsystems and learn a little bit more about the obliques, learn a little bit more about hamstrings, then come join us on Tuesday and take a look on our social media. You'll see the feeds for the posts for the ID Collaborative. Or you can go to the website. Anna's put up a link that says ID Collaborative right there on the homepage. Click on it. You can read all about the ID Collaborative. And again, that's not the ID courseworks. It's just our way of meeting a couple of times a week, maybe once, maybe twice, to talk about condition-based stuff. On Thursday of this week, I believe we're talking about allergies. Is that right? The anatomy of allergies, which is super fun and interesting. So we'll talk about some of the pathomechanisms as well as the regular mechanisms of the allergic response. So pretty fascinating stuff. We always have some pretty interesting topics at ID Collaborative. So hopefully you'll join us either online for a course or you'll join us for the ID Collaborative soon. If not, we'll see you on Sundays, every other Sunday at Ask Us Anything. We'd love to have you on here for free on this webinar to ask your questions. Thanks for joining us, and we'll see you next time. Bye.